So, my understanding is the first and foremost is what to do if you guys see a convulsion. Is that where you guys wanted to start? Awesome. Okay, so I like to start with seizure comes in many flavors. One flavor is convulsion, and that's the flavor that we all think about, but there are other flavors that we're going to talk more about today. So convulsions generally are a movement type seizure where the whole body goes, and usually, fall down and froth at the mouth and flop like a fish is what everyone thinks about. But just so that you're clear when I'm talking about it, we can have the whole body, or we can have one part of the body. So the problem there is you aren't always going to be sure if they're doing something funky, if it's a stim or not. And so there is a type of seizure where someone is having a movement or even a jerking movement, and it might look like a stim. And the big way to tell the difference, let me put this down for a second, is if someone is, of course, if they're blanking out, then you know that's not a stim. But some people can be wide awake. So one of my patients who's older and can really verbalize says when her hands do this, she knows the seizure's coming. And she can do this for 3 minutes before a big seizure comes. And so she waits, and if it's going on for 2 minutes, then she'll take a medicine and stop it from progressing. But she's not altered in any way. And so if you're seeing a repeated movement that's jerky, and it often will start either in the foot or in the hand, and it always is flexor. So if it's arm, it's flexion, or if it's wrist, it's flexion, if it's thumb, it's flexion. So it's always a flexor movement. And if it's like that, that can be a simple motor seizure. Simple being you're not altered, you're still yourself. So if you guys are in the middle of therapy and he's doing this, and you guys are, look at my eyes, and so he looks at your eyes, but it's still doing this, you might want to think about it. This, no, that's not a motor seizure. Because it's usually one side or the other when it's a simple partial, because it's from one part of the brain. Sorry, off topic again. Hold on. Let me go back to topic. Okay, back to topic. Convulsion, whole body. That's what we all think about. We all think about the whole body and this, okay? Now, to be clear, I have seen plenty of this. That's not a seizure, that's rock and rolling. That can be, in our brighter manipulative kids, a pseudo-seizure, where they want to get out of it. They've seen mom have a convulsion, or they've seen other people have a convulsion. They're done with work for the day, and they're rocking and rolling, okay? Anytime when almost always the eyes are open during it, which I have a hard time doing with my eyes open for some reason, but if their eyes are closed or if they're going in the no instead of the yes, no, usually not a seizure. Yes, a seizure. Now the other one is tonic, and that's the one I see a lot with our autistic kids because it's hard to tell if they're having a tonic kind of, I'm so pissed at you right now, or I'm so excited, that kind of, if it's tonic and it has a little thing, it can do that too. But the key is usually, even though I'm holding something, the hands are open. Usually the toes are also in extensor posture, not flexor, but extensor. It's just the opposite. And they're out of it. So that's hard because some of our kids do this and then they're back. That's probably not a seizure unless it's really an extended tonic that you're like, okay, they're going to fall out of that chair. Then we worry more about it. Wow, one part, and then tonic, and then there's atonic, and then there's what we used to call grand mal or generalized. Now you know why they use such big words, because once you know that there's tonic, that's extension, and then there's movement, that's extension, flexion, and then there's repeated flexion, you go, okay, that's why they use so many words for convulsions. The one other one that, well, I'm going to get to that one later. No, I'll get to that one now. So an atonic seizure, I'm only going for now because we talked about tonic. So if tonic is full stiff extension, atonic is complete lack of extension. So the most common way that atonic seizures present is just with head drops. And unfortunately, folks with atonic often have Lennox-Gastaut, and they look pretty darn autistic. And I think there's a big trend to calling a lot of folks that don't look typical autistic. But our Lennox-Gastaut atonic seizures kids, they're not making good eye contact, and they're not paying good attention because they're often having a lot of other little seizures too. But the head drops, if you see it looking like someone cut one of the strings on a marionette, that ain't normal. I don't know, do you guys think you've seen that where you're sure it's not a seizure?
Yeah, I used to have a kid at the school that I used to work at. I didn't know that he suffered from seizures. And so we were actually working one time at his college, and he just fell out of his seat.
Yeah.
And that's how I knew that he had.
That kind of does it, doesn't it?
Yeah. I mean, at first I thought he just like fell out because he was just bored or fell asleep.
Right.
And then he can also, he can just be walking, and it'll hit him, and he'll just fall wherever, you know. But yeah, that's what I always wondered about it. Because he doesn't have any convulsions, nothing, it's just completely lights out.
Right. I wasn't off mute, I'm sorry. Is that too loud now, or is that okay? Sorry, turned it on, off mute. Okay. Now you guys have seen all sorts of stims. You guys have seen and those things. Have you ever seen just a head drop as a stim?
Oh, as a stim?
Yeah. Yeah, okay, good. Because I wanted to make sure you were all like saying I'm with you that that's not a typical stim. Just I'm in the middle of doing something and I lost my head and now I'm back. And I've seen so many stims that it's hard to say. And I've seen stims that were, or we're looking to one side, but I've often seen it with the finger more than but I have seen the eye dart stims. You guys seen those? I don't know that those are all seizures, so that makes it tough. All right, back to business. Whole body convulsion or fall out of the ground. What are you guys going to do? Basics. Number 1. Don't panic. Number 2. I did it again, didn't I? Okay. If you can, roll them on their side. The only reason is that a certain percent of folks who have convulsions will vomit. And if they're on their back and they vomit, then they can aspirate. One of my toughest patients is one that the first seizure they ever had was at night. They were sleeping on their back. They like to get between the box spring and the mattress. Seriously? And he had a convulsion, vomited, it went into his throat. He had to be in the ICU for 3 days and almost died. Wow, how do I treat that when he doesn't have obvious seizures we can see? How did mom and dad notice that? They heard a funky gurgling from under the mattress. So we roll them on their side mostly in case they vomit. If they start vomiting, you just support them. If you can't roll them on your side, you don't. You do not restrain them. And we have this video, we do these video EEGs, where the parents go, oh, it's a video. They push the button, that mom calmly gets the video right into the kid's face. And then dad holds the kid down. And it gave us the opportunity to go, let's not let him bruise, because his body's going to keep moving. It's not going to stop him from moving, and he's not going to get injured from the movements. But holding him, then you get bruises, especially when you guys are allied health professionals. Then someone will go, did you beat him up today? And you're like, no, he had a seizure, I had to hold him down. Now you know you don't have to hold him down. Okay, so don't restrain him. Number 4, one of my favorites, when I do talks to kids, I ask them, can you swallow your tongue? And all the kids, I love this is typical classes, all the kids will go, and then they'll go, no. And I said, that's right, it's attached. And I go, it's attached. And I said, you know what, go home and ask your mommies and daddies what they would do if they saw a seizure. Because they're all going to say, put something in their mouth to prevent them from swallowing their tongue. And then you can laugh and go, Mom, try and swallow your tongue. Because you can't. Okay, so the good news is you can't swallow your tongue. Now what the kids can do, or adults, is they can bite the heck out of their tongue. It is excessively rare for anyone to get a non-repairable injury to a tongue. I mean, people aren't going and then starting their seizure. We keep our tongues in our mouths most of the time. So the most bad thing that'll happen is they bite their tongue, and then it bleeds a little bit. But if you put something in their mouth, now they can break that. They can have ingestion of toxins, or they can get splinters in their tongue, and then they've got to go see the doctor to get the splinters out of their tongue, or they can break their teeth. And that's expensive and painful. So the bottom line, do not put anything in their mouth. Okay. It also would get in the way of letting vomit out. Again, another favorite story. There's an actor who said on the set, one of the helpers fell and started having a seizure, and everybody ran away. Which, first of all, really gets me mad, because if someone was having a heart attack, everyone would run to them. Everyone knows. You're sweaty, you're red, your left arm hurts, you clutch your chest, you fall down. We know what to do. We're not scared of it, we don't run away. For some reason, there's an accident on the freeway we all want to watch. But someone's seizing, we're all going to run away. I don't understand that. I'm trying to bring awareness. That's, again, what Purple Day is about. But he and only one other guy ran to the guy. And the other guy took out his wallet and put it in his mouth. And he went, "He's not an ATM machine," and pulled it out of his mouth. So I kind of love it when people are as silly as I am. But it's just a really good way to remember. They're not ATM machines. We don't put anything in their mouth. Okay, now number 5, we look at our watch. And number 6, we see if they have ID. So some folks that, let's say you see them on the street having a convulsion, they're not your patient, you don't know anything about them, and they have ID bracelet, you may not need to call 911. If they get 911 called every time they have a seizure, that's part of American bankruptcy to pay for the medical care. So, sorry, political. So anyway, anyway, no one likes to go to the ER all the time. So if it's a 2-minute seizure, if it's a 3-minute seizure, and then they're out of it and they're relaxed, you don't have to call 911. If it's someone you don't know, or you're sure it's their first seizure, then you call 911. And look, even I do it. I said seizure, but I meant convulsion. It's their first convulsion and their first sign of epilepsy. Of course, we're going to call 911. Now, so if they don't have any ID and it stops, then you just stay calm with them and tell them, you just had a spell. Not everyone's ready for the word seizure. Some people are. Some people freak when they hear the word seizure. I often will say, you just had a spell. If they already have epilepsy, they know what a spell is. And you're okay, and relax. I don't try and get their name out of them right away. Hey, what's your name? What's your name? Because they might be confused. And after a seizure, a bunch of people are actually kind of aggressive, and they're fighting, and they're trying to get away, which is fun if that's a baseline behavior anyway, to know what's going on. But you do want to restrain them a little bit if they're trying to get away after a seizure, because they're confused and combative. And the other thing is then be careful with that, because even though that's not common, it certainly is not fun either. All right, so those are the basic things that we're going to do if someone has a convulsion. What questions at that point? Yes?
You said look at your watch, so if it's beyond 2-3 minutes, then you call?
If it's someone that you don't know who they are, and you've gotten, and if you don't know who they are and they have a seizure, you're calling 911 anyway. But if they do have an ID, and it's 3 to 5 minutes, then you're going to call 911, unless you have another seizure safety plan. So it's someone where you know they have seizures, they're wearing their ID, but it's been 3 minutes and you can't wait any longer, or it's been 5 minutes and you can't wait any longer, then call. Some people's ID will say call after 5 minutes. Most people, it just says they've got a seizure disorder. Good question. Okay, now, what if they've got a seizure plan? Some people have a seizure plan and they have a medicine, and I'm going to throw these around, but it looks like this. It has a rectal gel. This is the soft rectal tip. You're not going to damage anybody.
None of those have been used, so you can pass them
None of these
around.
have been used. Totally promise. These are all samples. This is called Diastat. I understand. I know. Americans are already grossed out by the idea of where these go. So these go in the butt. There are special training programs, but I kind of think it's funny because I don't know, when my mom was younger and I was a kid and I might be vomiting, she'd go to the pediatrician and they'd say, here's some suppositories. And they would never say, let me train you on how to use those. Because they understood it went where the poop came out. It's just a different generation. This generation is like, I don't know where that is. I think we know. But if you guys go to a training session, there are actual training sessions on how to use these. And I just think it's kind of funny. So the medicine is actually just in this part. Okay, so this is one that's dialed to give the most medicine. Some people get upset when they go to push the plunger down, because the plunger will only move a little bit. And they're like, I don't think I gave it, I don't think I gave it. Because we expect the plunger to go all the way to the end. This is a handle so that your hand doesn't have to go close to where the poop comes out. That's all this is. The plunger is this long so that you can plunge only that amount. Guys with me? Okay. I've only had 2 parents do that. They give 2 or 3 doses because it just didn't feel right. All right. So I'm going to pass some of these around, and you guys can feel that it's totally not scary. And like a couple, I can go at different speeds. Now, oh wait, did I pass one that didn't have the green thing? Where's my? These all have the green thing. That's weird.
So
I'll show you.
So is this for after? Like after they're...
Okay. So here's the plan. First of all, I tell the parents when they're going to go get this to make sure. I need like a holster for my. Okay. To make sure that it's already dialed. It says here 15. It comes as 5, 10, or 15, or it comes in different ways. And you guys shouldn't, or 7.5. You guys shouldn't have to worry about how it's dialed. That's not your job. But the pharmacist should get it to the right dose, and then they depress this to make it ready. Why do they do this? Well, in a lot of drugs like amoxicillin, they might have 10 different strengths, and then the pharmacist has to keep them all on the shelves. With these being 400 per 2-pack, they don't want to keep all these different strengths on their shelf. So they made it easier for the pharmacist. But if a parent shows up with these, and they're like, here's their kit in case they have a convulsion, I just like people to know to look for the ready green ribbon on the top. Not that you guys should have to do that, I just want to let you know. So a lot of people then will have a seizure plan. So their seizure plan may be, if there's a convulsion that's 3 minutes or more, give diastat. And it doesn't even really have to say the dose because, again, it should be pre-dialed. But it's nice if they tell you the dose. You can never use it twice. So say the dose is 2.5, but there's 7.5 in here. Can I give 2.5 and then give another? No, it's pre-dialed to the right dose. So you have to just give what it'll let you give, and that's it. And so then we have handouts, but roll to the side. Easier to get to the right area that way. Pull down pants or up the skirt, right? Or in other words, expose where the poop comes out. And no one has to do this. You have to be a volunteer. You don't have to do this. You can go, I ain't doing that. There are too many lawsuits about people touching kids' butts. I'm not going there. But I really think it's better to if the parent wants it, they're not going to sue you if you touch their kid's butt. Anyway, and then you just insert up to the hub. See, I told you no one's going to fall asleep. So this is the hub, in case you're wondering. You don't insert just that much. Okay, it's okay. The rectum is that long. And for little babies, we have one that's smaller. We do. Okay, so insert up to the hub, and then basically inject, but I don't like that word because it sounds like I've got a needle. And then when you're pulling it out, no jokes here, you hold their cheeks together. What am I talking about? All right, so let's have a little visual here. Okay, so you put something into someone's butt, you just put it in, right? It's a kind of liquid gel. If you pull it out and they're doing this, where's the gel gonna go? So you put it in and you hold the butt cheeks closed and then you pull it out. Only a few of you are looking horrified. I really appreciate that. You guys are awesome. Yeah. Question? No. Oh, no, just you're just listening. I love that. Okay. So
No, he was volunteering to demonstrate.
we don't do that. Okay, so I usually say, let's hold it for another 3 minutes. And, you know, you're not going to have a lot of people who have this, I bet, but around the adolescent age is when we start seeing convulsions in our kids that are needing ABA. And I think it's really profound that a lot of them have seizures before that age, and then when they're 15 and they've got farther to fall is when they start falling. Can't tell you how many of them I've seen. And then when I talk to them, mom and dad say, oh yeah, he does that all the time. He just stops what he's doing, and he's been doing that for 10 years. And that's when I get really sad, because we had a chance of a better intervention. Okay, so this is what to do if you have a convulsion and you don't know the person, right? And then this is if they have identification and they have a seizure plan. I wouldn't go to a stranger who happened to be wearing some kind of diastat holster and do it. Now, if there's someone going, you know, and you look and you see an EpiPen, man, I'm doing it, right? But I don't know. I think I'd call 911 if it's someone I don't know, even being a neurologist. But you guys know the universal, right? You guys know that one. That's I need my EpiPen. Yeah, you do. That's I need my EpiPen. Yes. Something to erase. You guys didn't know I'd fill up a board.
There's an eraser there.
There is?
Yeah, right next to your.
Oh, you're right. This is a real stable thing here. Okay. Now I can write down in my tracker that I got exercise today. You guys are a good audience. I'm here every Tuesday and Thursday. So I shouldn't have erased this part. So seizure. We now know about convulsion, and that the convulsion can be the whole body. And we now know about tonic. Generally, convulsions last 3 minutes or less. Tonic spells, generally brief, 1 minute or less. So it's not something that you're going to be going, oh my God, oh my God. Generally, atonics, the head drops, they're often either just a part of a second or they're in clusters. And it's really not unusual that they're in clusters and then they're not even tired afterwards. They're totally awake afterwards. Yes?
You mentioned earlier, like, eye movement ones, like those, what would that be under?
Perfect.
Or what's that considered?
Okay, so then I want to go through a little bit of a difference here. Not that I'm trying to make you guys to be doctors or anything, but the patient will come in often and say they either have partial or generalized epilepsy. That is where this handout usually comes in. And in here they talk about partial seizures. And a simple partial seizure on your cheat sheet talks about the rhythmic movement of a limb or something else. So a simple partial could be so scared, and then they're fine. I had some kids where they'll run up to mom and clutch her, and then they're fine. Or they'll suddenly giggle. Please don't send me those. Most of them are not seizures, but then they're fine. Oh, I should never have said that word in my clinic. Now all the moms that are on the Facebook are like, I think my kid has that too, because he giggles out of nowhere. And I'm like, oh, please. So anyway, but it can be a seizure. And so anytime it's one part of the brain. So if one part of the brain, say the frontal lobe on the right, is going off, the eyes would go to the left. If the back went off on the right, the eyes would go to the right. I'm sorry, you don't even know that. It's kind of a fun little ditty to show off. And then there's complex partial, where they're not quite right. So they might start with this, and go this. And then they can keep moving or walking or doing stuff, but they're not quite right. So partial we think of as simple or complex, whatever. So the partial seizures are from one part, and they can be convulsive or non-convulsive. And so the eyes going to one side can be considered a non-convulsive seizure. But generalized seizures can also be non-convulsive. That's why I think it's kind of tough when we're talking about seizures, is parents and treating doctors often say, he's got partial epilepsy, or he's got generalized epilepsy. Or they use the old term, he's got petit mal, which means nothing nowadays. And in French, it's always meant little bad, as opposed to grand mal, which is big bad, which doesn't help me. So we can have partial or generalized, and each one can do non-convulsive or convulsive. And the non-convulsive could be eyes moving. It could be lip smacking is really typical. It can be, and then they're back. In our kids that are high functioning, if I ask them, are there times when you're like playing a game or you're running and everyone else is somewhere else and you don't know what just happened? Oh yeah, I do that all the time. Then I know that they're having non-convulsive, that they can notice. Then I can ask them to track them. Most of the kids that have non-convulsive are not aware of it at all. On the way here, I was on the phone with an expert in neurofeedback. And he was just telling me the story about one guy that had hemiparesis. They told him he had a stroke. He had poor attention. They were going to do neurofeedback. He's actually a real PhD in psychology who does real neurofeedback. And he said there was a seizure focus, just going. And so his poor attention was really just, he kept losing what he was doing because when he's not distracted, he's having seizures. And so there's a difference between shiny object and then I'm back. Okay, so once again, I'm in the middle of talking and then I'm back. That can be a seizure. Okay, I'm doing a preferred activity. I'm doing something I like. I'm playing my video game, and then I'm back. That can be a seizure. I'm doing a non-preferred activity. My ABA counselor's over. They're trying to get me to make eye contact. I don't like it. I'm going to go, non-preferred activity got interrupted by staring, preferred activity. Okay, so parents get that. So we're talking on this handout more about partial versus generalized. And on this handout, it says that there are absence seizures. Okay, so what's an absence? Have I just been talking about them? Yes. But I hardly ever use the word absence, and I love it if you guys don't use the word absence, because absence is defined by what we see on the EEG. I usually say they had a staring spell. They had a staring spell that interrupted their activity. And if you guys were seeing it, it would be great if you guys said that interrupted preferred activity. And that's the most helpful, because the absence is a very technical term based on an EEG, or it's misused. So non-convulsive seizure, I often will write in the chart because I don't want to confuse anybody. And then I talk about partial or generalized when I'm talking about my med choices, because that's when it really makes the biggest difference. This is an old handout, and it just has 2 epilepsy syndromes. We now know that there's at least 180 different syndromes of epilepsy. There are more people that die every year of epilepsy than breast cancer. There are 30,000 people in Orange County with epilepsy. 10,000 of them are children, and 1/3 of those are completely resistant to medical control. That's Orange County. That's not counting everybody that's not diagnosed. Depending who you ask, 20 to 40% of kids with autism have seizures, have epilepsy. The problem is all the old literature, and I've done this big review because someone asked me to talk about why epilepsy shows up when they're teenagers. And the key in that phrase is shows up. It doesn't start when they're teenagers. It gets noticed when they're teenagers. And part of that is all the old data was based on looking at charts from patients that were diagnosed as autistic in the 1970s. Well, who's that? You know, if you were diagnosed before 1970, you were pretty darn severe. And so people weren't going to notice partial seizures or non-convulsive seizures. They're going to wait till you're falling on the floor flopping. And so throughout the rest of all the articles I looked at, they talked about when convulsions showed up as if that's when epilepsy started. So the data out there isn't very good whether we're looking in the medical literature or not. Wow, it just got really serious. Okay, so staring spell that interrupts activity, repeated movements that are flexion, okay, with or without an interruption of activity, the rigidity that's not just the arm. I'm so excited you're here, you know, I mean, that's not what we're talking about, right? Not the I'm excited movement that you know, but the rigidity that is the arms and the legs. And then the atonics, those are the biggies. Now, the next thing I was going to go over, Brad, did you have a handout for or a bunch of questions I was supposed to answer in a row?
You're right on. You're right on target.
Okay. So are you guys good so far? Okay. Do you want me to? Yes.
Oh, I just have one question back to the medication.
Perfect.
I'm not sure if someone asked this, but do you administer the medication during the seizure or at the end?
If the seizure stopped, you don't need to give it.
Okay.
And I always say when the kids look horrified, I go, if you can say don't, you don't need it. Any kid that can tell you don't touch me there doesn't need to have diastat. The whole job of diastat is to stop a convulsion so that you don't have to go to the ER or so that you don't go into a 10 or 15-minute seizure. Because the longer a convulsion lasts, the harder it is to break. So some kids have it because they tend to go into 30-minute seizures every time. Other kids have it because they don't want to go to the ER every time. And because it gives parents something to do. It's very empowering. It's a lot less panicky when you've got something you can do, when you've got a plan. And if your plan is, watch him. After 5 minutes, he's still seizing, call 911. That's not nearly as empowering. For $400 a twin pack, though, if parents have insurance that'll pay for the ER visit and won't pay for the twin pack, I don't know. That's between the parents and the insurance company which way they want to go. But if they're going to have to put a second mortgage on their house for the $400, that's not most of the patients we're seeing here, though. Okay. Now, the other thing I was thinking we could talk about, other than detection, is are the medicines that the kids go on going to definitely dumb them down? And I hear this a lot from the parents, is they don't want to go on a med because they don't want their kid dumbed down. I mean, they'll use 1,000 supplements, but a med, I'm doing it again, I'm venting. So, meds. So when it comes to my seizure meds, all right, when it comes to the seizure meds, they are as likely as herbs or supplements or other meds to cause problems. And my job is to make sure that if there is a significant side effect, we stop it. When we think that there is something natural that can help, I'm not saying there's nothing natural that helps seizures. I talk about that a lot. But hemlock is really natural. And I don't know if you've ever read the book by the Hemlock Society. It's about how to make the final exit. In fact, it's called Final Exit. So when parents are saying, well, is it natural? I'm like, yeah, aspirin's natural and hemlock's natural, but I wouldn't give either one to my little kid. So most of these are not natural, but they can be very helpful. And my job is to, one, prevent convulsions. And I have this all as a smart phrase that goes into their after-visit summary that they get to take with them. 2, prevent the non-convulsive seizures. And I tell them that what I'm trying to do is get all those bursts of electrical energy to stop, because each time it's like a power surge in your computer. And every time you get a power surge in your computer, if you guys are old enough to remember, before we had surge protectors, which most of you probably aren't, your computer would blank out. And then people like my husband, who was then my best friend, would go, I told you to save every 2 lines. And I'd be like, I lost my document. So you'd lose what's in your short-term memory. You'd lose what's in the RAM of the computer. But you're not going to lose what's in the hard memory, what's already been put down. The problem with kids are they have 3, and us, all of us, we've got 3 kinds of memory. We've got our ultra short term, like our RAM. We've got our medium term, and then we've got our long term. During the day, if we have a seizure, we lose what's in here. During the night, if we have a seizure, we can't bring it from the medium term to the long term. So those kids where you do a therapy one day, you see they got it, they've gotten it, and the next day, it's gone. And you're like, I don't get this. I can work with you for a week, you can get it all and keep it all, And then another week, you can get it and lose it. Get it and lose it, get it and lose it. What is it? Are you not paying attention to me? It could be that they're not laying down the medium term to the long term because they've got seizures at night. I'm not trying to say you guys need to refer everybody to a neurologist. I'm just telling you what I see in my practice, okay? So I tell them I want to prevent the non-convulsive seizures so that we help them learn. And also, we can help their mood get more stable and their behavior more stable.